Hi, I'm Rami Levine, the President and CEO of Sanyona, a biopharmaceutical company dedicated to improving the lives of rare disease patients around the world through scientific innovation. We are so pleased to be the gold sponsor of the Raymond A. Wood Foundation's Pituitary Brain Tumor Virtual Family Conference, and we are particularly excited to be the presenting sponsor of the keynote session on hypothalamic obesity by Dr. Christian Roth of Seattle Children's. Hypothalamic obesity is near and dear to our hearts here at Sanyona. During this event, Dr. Ulla Felp Rasmussen of Copenhagen University Hospital is presenting promising data from a phase 2 study of our investigational drug Tesamet for hypothalamic obesity. We see the significant unmet need for new treatments to help manage this disease. We are working now with the FDA to align on a regulatory path, and we look forward to keeping you posted on our progress. Thank you so much.
Hi everyone, my name is Dean Carson. I'm one of the board members at the Raymond A. Wood Foundation. It's my pleasure to introduce Christian Roth. Christian's clinical work is based at Seattle Children's Hospital as an attending of the endocrine division. This work involves the care of children with early onset of morbid obesity, children with brain tumors and complex endocrine disturbances such as hypothalamic obesity, as well as children with other endocrine disorders. And I'm sure I'm as excited as everybody else is to listen to Christian's talk. So take it away, Christian.
Hello, good morning and good afternoon. I'm really glad that we have this meeting today. I really want to thank the organizers, in particular Dr. Alter, Dr. McCormick, and the Raymond Wood Foundation for putting this together. I think we planned to have this meeting in person already earlier this year, and then due to COVID, we needed to reschedule. So I'm really pleased that we can now meet, even if it's virtual, but I think we can connect, and that is so important for treating something that is so complex like hypothalamic obesity. I have to say, I learn a lot from our families, and very often, some parents come and ask me, have you heard about this? And can we talk about this development? And would that be an interesting drug to test? These type of questions are very stimulating. And I really want to encourage you to ask these questions. And again, because we as doctors, we learn from you also a lot. So with that, I wanted to start my talk. First, my disclosures. I have a few disclosures to say, but not relevant for this talk. Now, what is hypothalamic obesity? That is the first part of my talk. Then I want to talk about principles of body weight regulation and typical findings in patients with craniopharyngioma in particular. Then I talk briefly about the damage of the hypothalamus and the risk for hypothalamic obesity. And then finally, I want to talk about some considerations for treatment. Now, what is hypothalamic obesity? Now, the hypothalamus is really a key regulator for food intake, sensing of hunger and satiety, energy expenditure regulations, so how much we burn in our body. Then it regulates many different hormonal glands, like also the pituitary gland. Then it regulates the day and night rhythm, what is called the circadian rhythms, blood glucose regulation, blood pressure and heart rate, body temperature, which has also something to do how much energy we burn, physical activity and thirst. And that is not complete, but these are maybe the most important functions. And when do we see hypothalamic obesity? We see hypothalamic obesity in different conditions. We have, for instance, we know some genetic disorders can lead to a dysfunctional hypothalamus. Genetic syndromes, maybe most of you are familiar with Prader-Willi syndrome, which leads also to uninhibited food intake and excessive weight gain. But we see it also particularly in brain tumors and other brain damage, irradiation, and inflammation. Now, this graph shows you a typical situation, patient with a craniopharyngioma, which you can see here in the middle of your head. And then after removal, there's a big hole. So all this brain tissue is gone. That is part of the hypothalamus. And I have to say the hypothalamus is a very small area of the brain. The volume is only 4 milliliters, whereas the brain is maybe between 1,100 to 1,300 milliliters in size. So it's a very small but very specialized area of the brain. And you see here this excessive weight gain after surgery in the hypothalamus. And that's something what we see often in patients with craniopharyngioma, but also in other tumors that are located in the hypothalamus. Now, what is the typical phenotype of hypothalamic obesity? We often see, as I mentioned, obesity, and sometimes together with hyperphagia, which means that the food intake is too high. It's excessive and not relative to energy expenditure. The reason is impaired satiety. I will talk about this a little bit further. But then we have also often lethargy, low physical activity, low resting and voluntary energy expenditure, and then central pituitary hormone deficiencies, thyroid, adrenal, growth hormone, sex steroids, and then disturbed circadian phases, so sleep and temperature regulation are disturbed. Now, we did some studies in patients with craniopharyngioma, and one part was also to look at energy expenditure and activity. And so we took actimeters and recorded movement counts. And we did this in a hospital specialized for treatment of obesity. And we had patients with simple obesity or common obesity without any underlying disorder, and patients with craniopharyngioma. And the difference was remarkable, in particular during leisure time. So in the afternoon, when the kids could decide if they want to be active or not, the patients with craniopharyngioma had much lower movement counts. So that seems that, you know, they don't have the drive to be active. And I really want to point that out because I've seen that very often also in our patients. I want to summarize a little bit what we typically see as multiple problems in patients with craniopharyngioma and hypothalamic obesity. As I mentioned, we have hormonal abnormalities, and we have a low sympathetic tone, that is the drive, you know, being active, that is low. Reduced basal metabolic rate and physical activity, lower levels of appetite inhibiting hormones or lower responses to these hormones. So that's something what we tested also. Our body produces a lot of different peptides in the gut, so in the intestinal system. And if we eat, those peptides are released. Most of them are appetite inhibiting, and they bind to the brain and hindbrain. And what we notice is that the change from before and after a meal of these appetite inhibiting hormones is less in patients with craniopharyngioma. So maybe that is also part of this disturbed regulation of energy. Then we have very often hyperinsulinemia, and insulin is an anabolic hormone that might also contribute to excessive weight gain. And then we have daytime sleepiness and decreased melatonin levels. So melatonin is a hormone that regulates the circadian rhythm, so day and night rhythm. And patients with craniopharyngioma are known to have low melatonin levels, but not all of them, but some. Then we have also fatty liver disease in about 50% of patients with craniopharyngioma. That's something also to check in follow-up visits. And we have increased food intake, which is called hyperphagia. This is sometimes happening in phases. It's not always there, but I have seen that very often, particularly after surgery. So in that time, you know, up to 12 months after surgery, the phase of increased food intake that really leads to excessive weight gain. So that's a point, that we really need to address, that we prevent this excessive weight gain. I want to talk a little bit about pleasure to eat and satiety regulation. And this is also very fascinating. So, we have some fuel that is available. For instance, what is bought, groceries. But then our brain actually knows exactly what is liked and what you want to eat. And it also determines what you are craving for, and then it links also to some emotions. But then, so this is, we are somewhat aware of this part of the food intake regulation. But then there is also this hidden part, that's the hypothalamus, the homeostatic regulation. And we don't know how that works, and we don't feel that, or we are not aware of it. But that also contributes to the decision to eat at the end. So that's very important. It's very complex. Also, physical activity can regulate somewhat this homeostatic regulation of food intake. Now, if we look at the peripheral regulators of food intake, we know that the adipose tissue sends some signal to the brain, like maybe you have heard about leptin and adiponectin. Then the pancreas produces some factors that regulate food intake, but in particular, the gut produces a lot of different factors. I don't list them all, but just that, ghrelin, for instance, which is produced in the stomach, stimulates food intake, and then peptide YY, glucagon-like peptide 1, and lots of other factors are actually appetite inhibiting. And these factors, they bind to receptors here in the hindbrain and the hypothalamus. So that's important, because we have sometimes this situation that the hypothalamus is destroyed, but there's still an intact hindbrain. By binding to these areas, they regulate then higher brain areas that are, linked to behavior and food reward motivation. And finally, that leads to our food choice, meal initiation, and meal termination. I want to explain that a little bit more. If you look here at the left panel, that is the regulation of food intake in a healthy person. And you see here the time axis. And if you eat something, your hunger goes down. So after 20 minutes already, you feel that you are getting full. And therefore you slow down your eating and stop eating at a certain time point. Now, this is the situation in a patient, for instance, with Prader-Willi syndrome. And I said they have the disturbed appetite regulation or disturbed satiety. So this person starts to eat and continues to eat, and the hunger is actually not going down as quickly. It takes a long time really that the hunger goes down. And therefore, this person is able to eat much more until feeling satiated and getting full. And that is, I think, explaining a little bit the problem. We call this also meal termination. That means we are getting full, we should stop eating, but sometimes in patients with hypothalamic obesity, exactly this mechanism is disturbed. Now I want to give you a little overview. If we have weight maintenance, then the energy intake equals energy output. And I have to say it is energy extracted from food. And that's a little bit complicated because how much energy we extract from food is sometimes different from person to person. There are some people who do not eat a lot, but are still extracting a lot of energy and store it. Now this shows you here, if we have an increased energy intake by hyperphagia because we eat more, then of course this balance is not there anymore. And so there is more energy intake than energy output, and therefore the result is weight gain. It could be also that we have an increased energy storage. And I thought about this. Potentially, this is also the situation if we have really high insulin levels, because insulin is an anabolic hormone, and we store more energy, and therefore we gain weight. And then the third option is we have decreased energy expenditure. So it's also possible that somebody does not eat more than average, but the energy output is lower than average, and therefore the result is also weight gain. Now we test also behavioral measures of food intake, and that is shown here. I don't want that you need to read all these questions, but I want to guide you through this a little bit. For instance, we can measure acutely how strong is your desire to eat right now. And we use this 10 centimeters visual analog scales, and that can change, within minutes. So we test this moment right now. And so that's very helpful. That is a measure that we use in our studies. Then we use also the 3-factor eating questionnaire, for instance. One question is here: sometimes when I start eating, I just can't seem to stop. So that's a typical situation of a disturbed meal termination. So you start eating, but you don't feel full, and therefore you continue to eat. It can be as strong as somebody described it to me. One young woman said to me, sometimes I just need to empty the whole refrigerator. And I felt really sorry for this person, because it's such a big problem, if you don't feel satiated and comfortable because you're eating, and you just need to continue eating because this nice feeling satiated is not kicking in. Then a question here, for instance, from the Children's Eating Behavior Questionnaire is: my child's always asking for food. So this is a little bit a different situation that is telling me that there is no satiety. So you want to eat again. So, this is, leading to grazing for food, some snacking. Now this is close to Seattle. This is our Mount Rainier, which is a really nice spot for walking. Now we are almost half through this presentation. I want to talk about the hypothalamus and risk for hypothalamic obesity. Now, already in 1901, Fröhlich, who was a physician in Vienna, described this hypothalamic obesity syndrome. And therefore, in the old literature, it is actually known as Fröhlich syndrome. And he described a 14-year-old boy who had a larger tumor in the pituitary gland that was also reaching the hypothalamus. And this boy had excessive weight gain and some hormonal disturbances. So he, Fröhlich, recognized this entity, that means that syndrome that has certain signs, that are disturbed, like disturbed hormonal regulation, hyperphagia, and this excessive weight gain. Now, again, we see that in different patients that are located in the hypothalamus, like craniopharyngiomas. I have also here leukemia, because leukemia is the most common malignancy in children. And some of the leukemias require radiation treatment to the brain, and therefore we see also hypothalamic obesity sometimes in leukemia patients. And we have inflammation, head injury, neurosurgery as risk factors, and radiation, as I mentioned. Now, if we look at adult obesity in patients or in people who survived childhood cancer, there are certain risk factors, and one of them is, as I mentioned, cranial radiation. So that puts up, the odds ratio is a marker for risk, so it's higher than 1, and it's clearly related to obesity development. Another factor was glucocorticoids, so higher doses of glucocorticoids. And the third one was, and that's an interesting one, obesity at the time point of the diagnosis. So that is also a risk factor. So that means that the tumor itself can already cause these problems of disturbed energy regulation. I want to talk about the different types of lesions that we often see in patients with craniopharyngoma. Here you see one of our patients with a small, relatively small craniopharyngoma, mostly located in the pituitary gland that is here in this area, which is called the sella. The hypothalamus would be here, and you see that lesion, this tumor, does not reach really the hypothalamus. Here's the optic chiasm, so the crossing of the optical nerves. And he has had an endoscopic transnasal approach for removal of the tumor, and you can see the tumor is gone, hypothalamus is still there, this patient remained clean. A different situation is shown here. We have this larger tumor here, and you can see it also here in this section. And after surgery, you see this big hole, and the whole hypothalamus is actually gone. This is from here, this orange line, marking the anterior hypothalamus, and the red line, the posterior hypothalamus. So all this area is gone, and this patient was already overweight at diagnosis, but became morbidly obese at extreme obesity. Now, this is a graph from Hermann Müller's group, and what they showed is also something that is very important, that at the time point of diagnosis of craniopharyngioma, the body mass index is already increased. So 0 is average, and he used measurements from child health exams. So this is U1 to U9. U9 is at the age of 5 years. And what you can see is even before the diagnosis, there was already an increase in this body mass index in patients who had then later the diagnosis of craniopharyngioma. But the biggest change actually occurred from the diagnosis to 1 year later. You see really this jump up of the body mass index in most of these patients in the obesity range. Now, I wanted to start with our quiz, and we have a little quiz for you. So it's great, wonderful, great result. Thank you. Wonderful. Thank you very much. I think this is wonderful. You answered most of the questions. We are perfectly answered, and I really thank you for that. Now I wanted to talk about treatment. And I show you first result from the International Registry of Hypothalamic Obesity Disorders here in the US that is guided by people in Cincinnati. And so what we saw is that we have 81% who received nutrition counseling. So that's very common in patients with hypothalamic obesity. But then also a larger part received also pharmaceutical therapy, and a smaller part bariatric surgery. Now, among the medications that have been given were often metformin, dextroamphetamine, and then followed by Ritalin, orlistat, and only few ephedrine and caffeine. So these are stimulants. Now, it is very important to detect the problem early, so the excessive weight gain. So what I would recommend is, and we discussed this plan also with people in Denver, with the brain tumor team in Denver, so we work together on such a program. is to assess very early after surgery if the patient is already obese or crossed more than 2 BMI percentile lines since the diagnosis, or developed typical symptoms of hyperphagia. And if that is the case, either one of these symptoms, that should initiate weight management by diet and exercise. And if that is successful, then continue. It's very important to be consistent with this treatment. But if it's not successful, then I would add pharmacotherapy. So I would add it and not leave this. So diet and exercise is still very important. And I recommend to my patients, actually, in particular the older ones, to say, plan your day in a way that you have time for instance, for at least 30 to 60 minutes of walking. So even if, there are some problems with the eyes that you cannot, do sports or something like that, but walking is really helpful. And so to do that regularly every day, even if the weather is not good, is helping. I have seen that often. And now, we could consider also bariatric surgery in some cases, but only if pharmacotherapy does not work. Now, for the dietary recommendations, there are lots of dietary recommendations. I cannot talk in most detail about that, but one thing that seems to be important for me is to address the disturbed meal termination and to say, what is a normal portion? So think about this and set it up before starting to eat, because otherwise, if you wait until you're completely satiated, the food intake might be too high, and if you ask for seconds and third portions. So that is, I think, really important to be aware. This is a normal portion, and that's it. Another point is, it is very helpful to have very regular meal plans, so that there is no doubt when the next meal will be served at what time. But there's also no hope to obtain unauthorized food. And that addresses disturbed satiety. So that, we need to reduce the snacking in between meals. And that is a little bit also how we treat patients with Prader-Willi syndrome. So that is very similar to Prader-Willi syndrome. Now let me talk about bariatric surgery. There are lots of different techniques, but these three ones are the main techniques for bariatric surgery: the adjustable gastric band, sleeve gastrectomy, where you take out this curvature, the major curvature of the stomach to reduce the volume, and then the Roux-en-Y gastric bypass, where you actually put one part of the intestine up to the reduced stomach. And there are unfortunately only very few published studies looking at the outcomes of bariatric surgery in patients with hypothalamic obesity. It seems that only the Roux-en-Y gastric bypass is really successful. Very mixed results for sleeve gastrectomy, and only a few case reports with successful outcomes after the adjustable gastric band. Now, this is north of Seattle. This is the San Juan Islands, very nice area. I want to talk about obesity medications. We know that there are newer developments of obesity medications. Some of them are already off the market. For instance, sibutramine, which is not here, but also Belvic has been withdrawn earlier this year because of side effects. So that is always something to keep in mind. Not all of the medications are safe, and sometimes we do have also adverse events, and you need to balance what's if a patient is really doing well with a certain treatment. But what has been used in the past are the stimulants, dextroamphetamine, methylphenidate, and in few patients also caffeine, ephedrine, and sibutramine, which is now not on the market anymore, that have been withdrawn. Then anti-diabetic agents dioxazide and metformin. Dioxazide can cause also significant gastrointestinal side effects, so that's a limiting factor. Metformin, I mentioned metformin and fenofibrate, and then GLP-1 receptor agonists. And I think those are the most promising ones under in this group of anti-diabetic agents. And then we have other drugs like T3, so thyroid hormone medication. Octreotide is a medication that had been used to reduce insulin secretion, in particular in these patients who produce a lot of insulin. The problem is also here, we have significant gastrointestinal side effects, and therefore most patients do not continue that treatment. Then one promising one was beloranib, which had been tested in Prader-Willi syndrome and hypothalamic obesity, but unfortunately there were fatal outcomes in the Prader-Willi syndrome study, and therefore this had been discontinued in development. And then oxytocin, and I think oxytocin is also very interesting and promising drug. I wanted to share these results, which were published 2013. This is oxytocin intranasal application in adults with obesity over 8 weeks, and you see here the reduction of BMI in response to oxytocin compared to placebo. Now then there is this publication also from Eugenie Su looking at oxytocin in a low dose, and the response was very remarkable. There was a good reduction in the BMI, and that was also in combination with naltrexone, another medication, but I think oxytocin itself was already reducing the BMI, so that was a successful outcome. And then we have the study from Dr. McCormick. So I think I'm very, excited that this study is soon completed and we'll see the results. So that is a placebo-controlled crossover study over 8 weeks with oxytocin versus placebo. And I think that will guide us also in a new direction potentially. But these clinical trials are really important to find out if a drug is working. And we did a study in GLP-1 receptor agonist, exenatide Q weekly. That means 1 injection per week as an obesity medication. And we tested this as a clinical trial in 3 centers. So I did this together with Dr. Abusahab at Children's in Minnesota and Dr. Shoemaker at Vanderbilt University. And the idea is that GLP-1 is a gut peptide that promotes satiety, and GLP-1 receptors are located in the whole brain, but in particular also in the hypothalamus and the hindbrain. So even if the hypothalamus is destroyed by a tumor or surgery, there is the option, that this GLP-1 receptor agonist might work through binding to these receptors here in the hindbrain. Now, this shows you the layout of our study that we call ECHO trial. We included 41 patients, 10 to 25 years old, and we tested exenatide Q weekly over 36 weeks compared to placebo. And the treatment was randomized and blinded. And then we had an 18 weeks open label extension. And we looked at BMI changes, but also body composition, glucose tolerance, energy expenditure measurements, eating behavior with these questionnaires, and appetite regulating hormones. We don't have all the results yet because we are still testing and analyzing data. These are the baseline characteristics of our patients who were included in this study. You see that the age was completely comparable between exenatide and placebo, and also sex distribution was similar. And most of the patients had craniopharyngioma, but we had a few other tumors. And I just want to share one results slide here, looking at BMI % change in the upper panels and percent body fat change in the lower panels, and on the left side, exenatide Q weekly, on the right side, placebo. And what you can see is that the portion and each bar represents one person, okay? So you see more persons are reducing their BMI in response to exenatide Q weekly compared to placebo. But there were also a certain portion, who did not respond to treatment. And if we look at the body fat, we see about half of the exenatide treated participants reduce their body fat. The other half did not reduce. But in the placebo group, all are actually were increasing their percent body fat. So there is a significant difference. But as I said, not everybody is responsive or was responsive to this treatment. What I also want to share is that we saw some milder gastrointestinal side effects. And we know that all GLP-1 receptor agonists have this problem, in particular at the beginning of the treatment. So we see nausea, vomiting, and diarrhea. And these are all different types of GLP-1 receptor agonists, and they have more and less this problem. And with a different group, I'm working also on drug developments, and we are actually working on new molecules that do not have this problem. And so we are hoping that in the future we will have drugs that do not lead to this significant problems. I wanted to conclude my talk and have some take-home messages for you. First, structural damage of the hypothalamus can lead to hypothalamic obesity. Now, decreased sympathetic outflow and reduced metabolic rate and physical activity are characteristic for hypothalamic obesity. Hypothalamic obesity can be due to increased energy intake, increased energy storage, or decreased energy expenditure. Extensive hypothalamic damage affecting the posterior hypothalamus has the highest risk for hypothalamic obesity. I showed you this slide with the big defect after surgery, and that was really reaching the posterior hypothalamus. Hypothalamic obesity often occurs during the first month after hypothalamic surgery, so it is very important to prevent and treat hypothalamic obesity early. Weight management should always include diet and exercise. Medications might need to be individualized. No treatment fits all. So in the future, maybe it is important to test treatments and to develop some algorithms how to test relatively quickly different types of treatment to understand if a patient is responsive to treatment or not. But I think medications need to be tested in clinical trials because there are lots of case reports and experiences, but we cannot move forward with this problem if we don't test them in really rigorous clinical trials. So that's something I'm asking for, and I thank everybody who participated so far in clinical trials. Bariatric surgery can be considered in patients who were resistant to lifestyle changes and pharmacotherapy. Now, finally, I want to thank you for your attention and that we can talk about this problem together. In particular, I want to thank to all of our patients and their families who participated in clinical trials and exchanged ideas and experiences. I want to thank our collaborators and also our team members. And now we can talk about questions that you might have.